is really cool. So hello everyone, welcome, and it's really nice to have every one of you here today. I get to discuss with Ravi a case. So if anybody has a case they brought to this VMR today and want to share that with us, it'd be really cool if you could write it in the chat or unmute and tell us if you have a case for us to discuss. And also feel free to turn on your videos so that we can see who's in the group.
I have to say it's my pleasure to discuss with Leah today, actually. So I'm a big fan of Leah. She's been here for quite some time and always has something interesting in the chat that I learn during each VMR. So it's great to co-discuss with Leah for the first time on this Tuesday VMR. And I'm very happy to see there's actually a CPS team VMR because everybody here, Hans, Madalena, Yasmin, Amanda, Marcella, Leah, Sammy, Deborah, Robbie, everybody's here today for this VMR. I see Austin is here today as well. How are you doing?
I'm good. Thanks so much. Long time here. I'm really excited that I had the day off so I could hang out with you guys.
Awesome. I guess some of us are getting ready to watch the World Cup at 2 p.m. EST, Argentina versus Croatia. That'll be an interesting one. So again, I'll put it out there. What Leah had mentioned, if anybody has a case, please feel free to come on in and just present if you can. Leah, how have you been?
I've been good. Just got a bit of a cold, but I feel like at least in our region, we have a big wave of common cold and influenza. So everybody has a bit of something. I don't know, how is it? Is it the same in your case as well?
Oh yeah, we've been very busy. A lot of URTI, flu, RSV, then mixture of COVID and this new strain. So yeah, it's very, very busy, just like Sammy had mentioned. So the whole world, I think, is just affected by this triple-demic, they call it. Interesting term for this occasion.
Yeah, I guess it's also the season now. We're all in. It's kind of cold outside. So is anybody have a case? I don't think I've seen anyone yet in the chat.
Oh, Yasmin mentions in Texas it's bad as well. Hello, Joy. How are you? All right, if not, I guess we can call on our backup case.
Yes, I guess we can lean on Maddie. I think you mentioned you have a backup case.
Yeah, I'm happy to share. This is a human DX case, so not one I personally saw, but it seems like it'll be a great case to discuss.
That'd be great. Thanks.
Okay. All right, Amanda, thanks for sharing your screen. So we'll jump into the first aliquot. So this is a 48-year-old man presenting with dyspnea, cough, and fever. To give you just a little bit more information, the fever has been going on for 3 days. The highest was 102 Fahrenheit at home. And I'll actually give you a little bit more information. So in terms of the cough has also been going on for 3 days. And the patient says that it's associated with sputum, mild dyspnea, and mild pleuritic chest pain. So I will pause there.
Wow, okay, thank you. I think we have a lot of information here already. So we have this middle-aged male who presents with an acute phase of dyspnea, cough, and fever, and pleuritic chest pain as well. And the cough is productive, so yes, sputum. So a few questions, like there are so many symptoms we could tackle, but the first thoughts that I had was dyspnea. Okay, dyspnea, we think of, is this cardiac, is this lung, or is this other? And I think because this patient has fever as well and this inflammatory syndrome, lung is something that I prioritize reflexively. So even though the others are not included, that's my first thing I go to. And I think this is even more probable because he has productive sputum. Now I would ask, what does the sputum look like? Is this just colorless? Is it with blood, or is it like yellowish, who was more into like bacterial infections? And now I think you mentioned it was pleuritic chest pain. So pleuritic chest pain for me is something that is in contact or close to the pleura and irritates it. So this could be just a very classic presentation of pneumonia, or maybe something that has to do with the heart, pericarditis, or something that touches the pleura from the abdominal space. So this is also a very broad symptom. But I guess a chest X-ray would be a good start for this patient, some basic labs and also exposure history, and just see what kind of risk factors he has based on his past medical history. But I feel like I've been talking for too long already. Ravi, what are your thoughts?
Oh, Leah, that was absolutely fantastic. I love the pleuritic description that you went through, and especially just visualizing the pleura and everything that it comes into contact with. And so I was just imagining a drawing. I think the CPS pleuritic chest pain schema has that drawing on there and shows the pleura in contact with all different surfaces, whether it be the heart, the diaphragm, and so on. But I agree, like the chat was mentioning, like Hans mentioning, we're looking at cough and dyspnea, and we're looking at it through the filter of inflammation, infection, because we have fever. So fever is possibly pointing us in the direction of an infectious inflammatory process. Now, my question is, like, 48-year-old having this, it's not uncommon. A URTI may have morphed into a lower respiratory tract infection. But I am kind of concerned at this point, somebody 48 years old having this kind of condition. So are we dealing with a host that may have some issue with impaired defense mechanisms? Maybe there's an immunocompromised status, namely maybe HIV, maybe there's some immunosuppressive medications. We've seen or had some VMRs where patients were on certain medications that could alter the outcome of the diagnosis. So at this point, I think we'll get more data, but I'm right there with you, thinking infection, inflammation, then pleuritic chest pain, something within the lung, plus or minus maybe the heart, pericardium. So let's see where Madalena takes us with the next aliquot. Back to you, Madalena.
All right, fantastic discussion, even after just the first kind of chunk of information. So additional information, so he does not have upper respiratory symptoms. And unfortunately, there's nothing listed here about the past medical history. So I'm gonna jump to the physical exam. So in terms of vitals, the temperature is 101 Fahrenheit, pulse 96, respiratory rate 26, and the patient is satting 96% on room air. So in general, the patient looks malaised. In terms of the pulmonary exam, there's a few right upper lung crackles. The JVP is normal, and there is no leg swelling. And I'll pause there.
Interesting. What do you think with now the exam, Leah? How does that move us diagnostically?
So I think looking at the vitals, this respiratory rate is quite elevated. Heart rate is also on the upper end. The SpO2, I don't know what you think, but with 96, it's not the optimal 98, 99, but it still is not extremely low. So I think he would be like in mild respiratory distress, which of course shows he has quite a high respiratory rate. So those are my thoughts for this. Then JVP is normal, which kind of makes congestive heart failure or right heart failure less probable, because it would be elevated if there is like blood that is flowing back and showing there. The crackles in the upper lobes of the lungs is kind of our shows us, okay, there could be, the focus could be in the lungs, because we had signs of inflammation, and then we want to find, okay, where is the inflammation located? So this again supports our hypothesis that it might be a pulmonary cause. Now, the leg swelling, again, for me in this context, is just something that makes heart or congestive heart failure less probable, but otherwise I don't have much to add to that. Yeah, I wonder, how would you interpret kind of the O2 saturation and upper lobe? I don't know, I was wondering, does it make a difference if it's upper or lower lobe? Maybe there's a pneumonia that is located upper lobe. Lower lobe crapulus could also be like congestion. But that's all I have for now, I think.
Yeah, excellent points, Leah. Yeah, I'm also picking on, so I'm going through this information, also picking apart the same details that you had honed in on. So namely, this patient has cough, dyspnea, fever, which has great specificity for pneumonia, namely like community-acquired pneumonia, but we're missing hypoxemia here. So the pulse ox at this time is fine. But who knows, as pneumonia, respiratory infections can be dynamic. An hour later, the patient may be having hypoxemia. So at this point, it's sort of early to say that this is probably not a respiratory infection. But then thinking about this right upper lobe, the abnormal lung sounds could be something within the lung. So what could it be? Could there be fibrosis? Kind of odd to have fibrosis just in like a singular part of the lung. The pan usually does not follow this trend. Okay, what else could there be? Could there be something within the alveolar fluid? But again, just within one portion of the lung is sort of odd. Could there be atelectasis? So if the right upper lobe is fed by the right bronchi, could there be something compressing the bronchus? Could there be something endobronchial, lymph node, tumor, something that could be then causing the abnormal sounds? And when you have atelectasis, then the imaging will be very helpful. You'll tend to see collapse on that side and shift of the mediastinum, trachea, and then also movement of the diaphragm upward. So those would tend to indicate to you maybe an alectatic process. What else could you have? Something within the alveolar. It could be pus, blood, fluid, or cells. Kind of early again, but with cough, dyspnea, fever, makes it very likely that it could be infection. Most common infection will be a CAP, and the various organisms mentioned, strep, flu, H flu, and so on. I don't see anything in the past medical history. Patient isn't immunocompromised. So the host features don't dictate that something ominous is going on here. Maybe something that could be fungal, nothing occupational. Yasminda mentioned travel history is very pertinent here as well, but we don't have anything like that. So I think we have to then boil it down to the most common causes, which would be like CAP. But again, I'm kind of puzzled by this right upper lobe process. Somebody had mentioned aspiration pneumonia. That could be something, but right upper lobe, usually middle lobe, I guess, aspiration usually will happen on the right side because of the more horizontal, the bronchi would be, I guess, anatomically located more easier for aspirated materials to then move to the right side versus the left side. And TB was mentioned. I think that came to mind. System one thinking, a spot diagnosis would be, TB, upper lobes. He has a predilection for that. But then again, I'm not seeing like weight loss or really heavy inflammation. And it would be a more longer drawn out process than somebody just having 3 days of this process. But then again, it's kind of too early. So I just don't want to rush the judgment and exclude it. So we'll see what else comes up with Madalena's next aliquot. Any other thoughts, Leah, before? Sometimes like when we discuss the other person, you listening to the other person, and it triggers thoughts. So before we get underway with the next aliquot, I just want to give you a chance if something came up.
Yeah, as Sammy said, I'm loving the discussion. I love how you guys are kind of dancing between the lung and the heart, and how after the exam you really focused more on the lung and focusing on the base rate. So really fantastic discussion.
Yeah, one
All right.
one more thing. I think
yeah.
Leah had was she was muted. I think she was saying something, but I just want to say like we're thinking infiltrate, but what if there's a cavity, and then that brings up a whole bunch of other possible diagnoses. So what if there's something there in the right upper lobe? You can have cavities, you can have maybe a malignancy, early 48 years of age, possibly non-smoker, but that we have to think of other things than just a infectious infiltrate. Leah, did you have any other thoughts?
No, I think all I was thinking okay, these new thoughts now with the cavity and malignancy, might there be something? Yes, but this is still quite acute in onset, and we don't have any constitutional symptoms. Of course, that doesn't exclude it, but those were just some thoughts. And then I think imaging would be really helpful and interesting here. So I hope I will get that in the course.
All right, so I'll give you a little bit of what you guys were asking for. So for the hematology, we have that the white blood cell count was 16. Hemoglobin and platelets within normal limits. The chemistries are unremarkable. There was a viral PCR of the nasal swab, which was negative. And they got a chest x-ray, and I'm actually going to share my screen to show you that. Continue. Okay, are you able to see the chest x-ray? All right.
Yes.
So so this is the chest x-ray. I can tell you what the read was, but I may let you guys make comments on it. And then the last piece of information for this aliquot is that there was a sputum gram stain which showed gram-negative coccobacilli. And I will pause there. I can tell you, if you want to make any comments on the chest x-ray, and then I can reveal what they said about that.
Leah, what do you think about this x-ray?
So from like my first impression of the x-rays, we have like good inspiration, and I look at, are there any effusions? So I would see this if there would not be these nice demarcated margins at the lower end, which I do see, so I'm not too worried about that. Then of course, because then I look, okay, are there any patchy infiltrates or something that make it less transparent, which I don't see, like here. Maybe lower left, like next to the heart, it's a bit less transparent, but overall I'm thinking, okay, this patient had crackles on the right side upper lobe, and I'm looking there and I don't really see anything. I don't know, do you see something, Ravi?
Yeah, when Madalena put this x-ray up, I immediately looked to the right upper lobe, and I don't see anything there. So if I had a very high pretest probability for something ominous developing in that right upper lobe, I think sometimes a CT would give you better definition if something's not apparent, and an X-ray can be good, but you can miss a lot of things. But if we really want to get to the minute details of what could be going on in the lung, especially when we're thinking other things, and I just want to shout out Austin just reminded me of this great mnemonic for right upper lobe pathologies. So star chase, and actually I had something, we had a case many, maybe a year ago of right upper lobe phenomena, and I made a little schema for that. So I forgot about it, but thanks to Austin for reminding me. So star chase, so sarcoidosis, TB, non-TB, aspergillosis, respiratory bronchiolitis, cystic fibrosis. So the couple of things, just a rattle off that could be going on there. So I think we would have to proceed with a CT if we think the answer lies in the vicinity of that right upper lobe.
Yeah, fantastic. And I'll just say that as you both described, there was no acute abnormality noticed on the chest x-ray. So just reaffirming what you both noticed.
Yeah, let's also, I think we sort of jumped to the imaging, but there was a lot of information within that CBC and also the sputum. Leah, do you want to care to take a stab at that? Then I can follow up.
Yeah, sure. So I think there was leukocytosis and otherwise unremarkable CBC and labs. So leukocytosis, of course, if it's, then it would be interesting to get more details on the differential. But in general, I think if this is neutrophilic predominant, it's very compatible with the bacterial infection. Then I think also on the labs, or I think the sputum culture was gram-negative bacilli. That came back positive. And the shout out to Jasmine, who was already giving her differentials for that in the chat. But a very common pathogen that she also mentioned for pneumonia would be Haemophilus influenzae, which would also be one of my first reflexes when I think of pneumonia alongside Streptococcus pneumonia and other organisms. One time I learned, I think it was Sammy who taught me that Legionella could also do like a very localized infection in the lung, so a lobar pneumonia. But in this case, we have this gram-negative bacilli. So I guess I'm just wondering, yeah, we know this and then find out whether it's Haemophilus influenzae or not, or what exactly it could be, would be one of my next steps. And my thought for the chest X-ray, because this is still quite an acute process, maybe the infiltrate will still develop over time. So that's why we don't see it yet on the chest X-ray, and the CT would be more sensitive in this case already. But if this is just a community-acquired pneumonia, I think we give him treatment and then also follow up with a chest X-ray and see whether he improves or not.
Wonderful thoughts, Ellie. I just loved thinking to your logic and analysis of this data and how you're using it to move to a possible diagnosis there. And this development or developing pneumonia, I think Dr. Uncle Bob, we call him, or Dr. Robert Centaur, used to talk about this. I haven't seen him for a while on here, but we do miss him. Blossoming pneumonia. So blossoming pneumonia, patient not having the signs and symptoms, and your pretest probability for pneumonia is very high, but the imaging is not supporting that hypothesis. So you follow up with more imaging. And I also want to recognize Austin mentioning you could also use ultrasound, because getting multiple X-rays, you're exposing patients to unnecessary radiation and costs. So you could possibly get that initial X-ray. Everybody gets an X-ray in the emergency room, but then you could follow up with ultrasound. And ultrasound, you would look for what's called hepatization of the lung. I think we had one of the POCUS VMRs where you would demonstrate liver type pathology or imaging morphology within the lung. And in the right upper lobe, you may see that. And it has very good sensitivity, specificity, probably better than a chest X-ray at recognizing pneumonia. So blossoming pneumonia would be something developing, especially if a patient is dehydrated. By giving fluids, you may bring out or unmask a developing infiltrate. So maybe getting a CT if we're thinking something more sinister is occurring, maybe structurally, like and maybe a lung abscess or cavity or something along those lines, maybe a malignancy or a mass. But an ultrasound might be sufficient at this time. But I've learned over time, and the key word is learn, because sometimes we have certain thoughts about some of this data, maybe like a leukocytosis. My immediate system one thinking would be there's a pyogenic infection, especially if it's neutrophil predominant. But I've been blindsided multiple times. I think the last one I'm thinking about, I was like, this has to be pneumonia because the white count is elevated and it's pyogenic, but then it was something inflammatory. So we still have to consider, could this be a lung vasculitis? Could this be some other inflammatory condition? So we don't even know if we have a lung mass on that side as well. So we have to keep our minds open. I wouldn't just table maybe non-infectious causes, but take them off the table and strongly consider those other diagnoses, and especially that mnemonic that Austin had mentioned. Back to you, Madalena.
All right, and then just highlighting what I believe it was what Austin said. He said that, just highlighting that you're using kind of time as the best diagnostician and seeing how things would progress on imaging. So really amazing discussion again. So this will be the last aliquot. So I'm going to go ahead and share my screen because we have some more imaging as you both asked for. All right, so a chest CT was obtained, and I'll actually just pause here to see if you want to make any comments, and then I can also share with you what the read was.
Okay, so I see in the right lung lobe, towards the middle upper lobe, there's this demarcation, this triangular shape, and now what could this be? Could this be some kind of infiltrate? This kind of shape also reminded me of lung infarct, just because it can also have this kind of triangular shape. But then I can't go more into depth on that. All I would be wondering, so I think infiltrate or infarction are the infiltrate because of the history and infarction because of the shape. Those would be my associations, but I don't know. I can't say much more about it.
Leah, that was great. You recognized this triangular abnormality, which is following possibly a vascular territory there. So a wedge like that, bang smack right against the pleura, and explain the pleuritic chest pain. And that was you absolutely blew me away. PE definitely comes into consideration. And I think on X-ray findings like this is you get something called Hampton's hump, which is the infarction of the lung, which may be apparent if it's progressed enough to be on an X-ray. But here we have the finding on a CT, and it's very suspicious for pulmonary embolism. Yeah, it's not following like a low bar picture, but again, this could be early. But I'm sort of the light bulb is going off, and it's like pulmonary embolism is very, very suspicious at this point. Back to you, Madalena.
Yeah, so the read here was, as you both mentioned, an airspace opacity in the right upper lobe, and it also says no evidence of pulmonary embolism. So that's the last piece of information I have. So if you both want to kind of share any last thoughts before I share what the final diagnosis was.
Sure. So I think from previous experience, seeing something like CSP comes into mind. It's not a bad thought. I think in real world medicine, that would be a consideration. But then again, like Jack has mentioned, this patient had very, very low pretest probability for that. P was not something I would have considered from the get-go. So we're talking about when trying to break down dyspnea, patient did have cough as well, had fever. You can get those with pulmonary embolism, but patient did not have hypoxemia. Patient didn't have hypotension, tachycardia, heart rate 96. So you can sort of give that. The legs weren't swollen. That would give you more suspicion, maybe if you have unilateral edema, and especially if the patient has a risk factor for pulmonary embolism, that would increase your pretest probability for that. So very unusual morphology for this process, but there definitely is something that's abutting the pleura and causing this chest pain. So I would go back to that differential for the upper lobe processes, and then also consider that what was in that sputum. So all of the Ellas that Yasmin had mentioned, Haemophilus, Brucella, Pastorella, and so on, Francisella, these do, I guess they are hard, they do take residence in the upper lobe. So I would strongly consider that. Anything else, Leah? Does this do anything now? We've taken our primary thought and just thrown into the wastebasket, pulmonary embolism. So we have to move beyond that to something else to explain this presentation.
Not much, just I think one point I want to mention, I thought it was great that throughout the discussion, you always took a step back and stayed broad and considered also other differentials. And even though this might be, or it seems to be like a classic presentation of a pneumonia, it's always important to go back and weight other things with more sinister background could cause a similar presentation as well. And now I think I'm still kind of surprised and puzzled at the presentation on this CT. So I'm excited to learn about what kind of process causes this shape. But the only real material that we have that's a bit more concrete is the sputum culture. So I think because of that, I would still go with an infectious cause of pneumonia, and then that would be, I guess, my top differential.
Okay, Madalena, back to you.
All right, phenomenal discussion. So before I give kind of the result, did either of you want to touch on how you would approach treatment in this case? If not, no problem, and I can share with you what happened. Just wanted to see if either of you wanted to talk about that.
Leah, what do you think?
It's a good question. I think I guess it depends then what kind of organism it is, obviously. But gram-negative bacilli for antibiotics. I think if it's Haemophilus influenzae, okay, I'm not going to say, well, I'm not sure if the classic amoxicillin would work for that. But I think some kind of penicillin might. And I guess the standard would be like 5 days of antibiotics. But yeah, so I think I would treat the patient and then see what how the symptoms, labs, and imaging kind of evolve. But I'm really not an expert on this. So I guess, Ravi, help me out, please.
Oh, no, you did great there. Yeah, if you're in the territory of what kind of antibiotic groups you would consider. So this is a patient coming in is not severely sick, needing intensive care unit care, and in that case, you would have to then consider multi-drug resistant organisms like MRSA, Pseudomonas. There's also second, there's no previous hospitalization or exposure to antibiotics that would make you consider resistant organisms. Then again, no MRSA, Pseudomonas, and so on. In this case, patients coming from the community, I would consider then just conventional, what could be amoxicillin, clavulanate if outpatient, and for atypical coverage, doxycycline, maybe over azithromycin. Inpatient, if this patient meets criteria, and we have some risk assessment scores, CURB 65 or the pneumonia severity index to determine does the patient need inpatient care, or we could trial an outpatient antibiotic regimen. And if the patient is severely symptomatic and needs, namely if they need oxygen, they would come in, or hemodynamics are impaired, and they go to a regular medical floor without monitoring, maybe ceftriaxone and zithromycin plus or minus, ceftriaxone plus zithro, or ceftriaxone plus doxy. And doxycycline considered more of azithromycin nowadays because of QT prolongation side effects, and even C. diff can be, or risk for C. diff can be increased with azithromycin. So I would start there and then see what else we would do, other tests, blood cultures. If they're outpatient, we wouldn't necessarily get those tests, but inpatient blood cultures and the sputum, the urinary antigen, Legionella, strep pneumo, and then see what we have. Back to you, Madalena.
All right, amazing discussion, both of you. So the patient was diagnosed with community-acquired pneumonia and treated with ceftriaxone. So sputum culture grew H. influenza. He improved and was transitioned to amoxicillin on discharge. And so I have a few learning points here that's included in the case. But do you guys want to say any reactions or anything before I jump into that?
Leah?
I think my reflection at the moment is still at the imaging. So I'm excited to see if some of the teaching points will explain that.
Yeah, I'm also bowled over by the imaging. It's not typical, but I guess coming to CPS, you'll get sort of these atypical pictures. But this demonstrates that the X-ray wasn't very good in describing this infiltrate to us, but the CT was showing an early infiltrate. There was a study done in the emergency room where they found CTs. If your suspicion is high, a CT will give you a image of an early pneumonia that's in evolution versus a X-ray, which may not show you the pneumonia if it's not advanced enough. And going back to Uncle Bob's blossoming pneumonia theory. And yeah, the last time I had a VMR like this, I was like, it's got to be capped. It was something else, but this time it's capped. So a great review, especially for students, and something that we see commonly around this time of the year. So it's great to go through the thought process and also the antibiotics, very, very high yield. So thanks for the case, Madalena, and Leah, great job.
Yeah, I just want to echo how incredible a discussion, Leah and Ravi, both of you. And the teaching point does relate to what you both commented on, which was kind of the surprising chest x-ray, which was normal. So it says here that in terms of the illness script for pneumonia as it related to imaging, so chest x-rays can miss up to 30% of pneumonias. And if clinical suspicion is high, chest CT is the definitive way to evaluate for alveolar inflammation. And it says that pneumonias which are chest x-ray negative but CT positive have similar clinical severity, microbiology, and outcomes as those which are chest x-ray positive, and should be treated and should not be treated as less severe. Another pearl that is here is that venous thromboembolism can also cause fevers and was in the differential until the CT scan and sputum stain culture confirmed an alternate diagnosis. And those are all the pearls we have written here.
Wow, incredible, Madalena. That's that just impacts, the way we diagnose pneumonia. I always teach my students, go through history, the physical, the labs, and then the imaging, and not to jump to say, why does this patient have pneumonia? Oh, because there's an infiltrate on the X-ray. And many times I see in X-rays showing some opacification, and there's a diagnosis on the imaging of possible pneumonia being treated as a pneumonia, but there's no signs of inflammation. Namely, there's no symptoms, no cough, no fever, no white count, and so on. So you always have to be very careful. Sometimes you get an X-ray which showing pneumonia-like features, but is not an infection. Sometimes you get a patient coming in with pneumonia-like symptoms and the X-ray is negative, and this is a very powerful case that shows the utility of additional imaging to support your hypothesis. So great case there. I really appreciate it, Madeleine.
Yeah, I also want to thank you for sharing this case. I think it's so important to also go through these common presentations and still, as Ravi always reminded us, take a step back and not just go with what is most evident, but also consider other things, as it was possible until we had kind of the exclusion of pulmonary embolism being there. But it was a great case to learn from, and thank you, Maddie, again.
Yeah. And Leah, you did a fantastic job. I just followed you everywhere. So you had already laid the path for getting to the diagnosis. I just hung on to your coattails and just followed along with you. So I really appreciate you coming and co-discussing today. Should we move on to the teaching points?
Yeah, sure. Wow, thank you so much for this amazing discussion, Leah and Ravi and Maddie, for jumping in and presenting the case. So this discussion was full of pearls. I think we all learned so much. So we first approached dyspnea, which we already did often, and which, as always, we should always prioritize lung and heart over others. For example, anemia, acidosis, thyroid disease, neuromuscular weakness, psychogenic it's very important to remember that dyspnea is a subjective, is very subjective, and to some people dyspnea that to other people it doesn't. So that's very important to keep in mind. Then something I learned from Ravi is that you should always ask 3 questions when somebody comes with dyspnea. Are there signs of volume overload, which prioritizes a cardiac disease? Are there signs of pre-syncope or syncope, which also prioritizes a cardiac or pulmonary vascular cause? Or are there signs of inflammation, which prioritizes more of a pulmonary cause? It's also important to mention that you can get other structures inflamed inside of your thorax, for example, infectious endocarditis, myocarditis, etc. Then we had this finding of pleuritic chest pain, which made us think about which structures are close to the pleura, mostly the lung, with pneumonia, bronchitis, and PE being common findings or common causes of pleuritic chest pain. Pleural causes, for example, if you get primary viral pleuritis, mediastinal causes, for example, pericarditis or mediastinitis, for example, and abdominal causes, not to forget, especially if you get hepatitis, cholecystitis, or also splenic infarction can present that way. Then we talked about infection and what it's important to consider when you think about infection. Always think about the host. What is the season? Are there any risk factors or certain exposures to think of? Here, there were no real exposures except that the patient was from the community, which everyone is. So then we had talked about the typical location for aspiration, which is mostly the right lobe, especially the right middle lobe and right lower lobe due to the anatomy. You can also get aspiration pneumonitis from aspiration, but that presents more acutely and more inflammatory. It just has a much more quicker onset than, for example, aspiration pneumonia. Then we had the findings of cough, fever, dyspnea, and local lung crackles, which immediately made us think about community-acquired pneumonia, which is mostly due to strep pneumo, H. influenzae, mycoplasma, chlamydia, but also think about Legionella. And I think the most common cause, especially over the last 2 years or 3 years, was viral for sure. And if you have viral pneumonia, you typically have upper respiratory tract infection symptoms, for example, sinus congestion, runny nose, stuff like that. Then we learned this great mnemonic for upper lobe lesions from Austin, STARCHASE, which stands for sarcoid, TB, or non-tuberculous mycobacteria, aspergillosis, respiratory bronchiolitis, cystic fibrosis, hypersensitivity pneumonitis, ankylosing spondylitis, silicosis, and also eosinophilic granuloma. Then we had this interesting finding of the sputum being positive for a gram-negative coccobacillus, and Yasmin was right on top with H. influenza, but there are also others to think about. For example, Legionella pneumophilia, but the gram stain isn't too often positive, and rarer causes to consider are Coxelia burnetii, Francisella tularensis, and also Bordetella pertussis. And a very important teaching point of this session was that a negative chest X-ray does not always rule out community-acquired pneumonia. In fact, up to 30% of community-acquired pneumonias can have negative chest X-ray on primary presentation. So if there's a high pretest probability, you should always get a CT4X, or not always, but you should get a CT4X or a POCUS examination of the lung, which is very reliable and easy to do. You just have to do it and try it. And findings that you can see on pneumonia, on POCUS of the lung, are local B lines. For example, in heart failure or volume overload, you would have them diffusely. Very specific is also an irregular pleural line, which prioritizes an inflammation or infection of the lung over like fluid overload state. You can also get hepatization of the lung, as Ravi taught us masterfully, plus minus a pleural effusion, which isn't too sensitive or specific, I mean. Then we had this interesting finding of a wedge-shaped lesion in the lung, which made Leah immediately think about the PE. And there's a certain sign that's called Hampton hump, when you get peripheral emboli and infarction of the peripheral tissue, but also think about infiltrates due to infection or, for example, local inflammation. And Austin also said in the chat that it's very important to get like a three-dimensional image because a wedge-shaped lesion isn't too typical for infection. And another great pearl was that infiltrates due to pneumonia can take up to 6 weeks to resolve. So don't be too quick with saying no, that patient doesn't respond only because of the lung findings. Always look at the patient and don't treat the chest X-ray. So thank you all so much for this great discussion. And I hope you all have a great rest of your day.
Thank you, Sami. That was incredible. Putting all those teaching points together. I absolutely appreciate it. Thank you, CPS team. Great presentation and great to see everybody here again today. So have a great rest of your Tuesday afternoon. Take care. Bye.